Hello, everyone. Today, our case is a 49-year-old male patient who is on dialysis, has a history of hypertension. He has been on dialysis for 7 years. He has secondary hyperparathyroidism, and he's on a dietary phosphate restriction, along with baricalcitol for mic with each dialysis, sevelamer carbonate, 3 tablets, 3 times a day with meals. His IBTH has ranged from 351 to 547 picogram per ml in the last 6 months. A new lab showed that his calcium, the corrected one according to his serum albumin, is 9.8, phosphorus 5.8, and his IPTH is 773. Which one of the following is the most appropriate next step in this patient management? Would you increase the baricalcitol dose from 4 to 10 microgram with each dialysis? Would you add 30 milligram of cinacalcet and gradually increase the cinacalcet dose according to the tolerability? Would you stop the phosphate binders? Would you add calcium acetate as another phosphate lowering therapy? Or would you refer the patient to parathyroidectomy? And the right answer is add 30 milligrams cinacalcet and gradually increase the cinacalcet dose according to the patient tolerability. And here is a take-home message. This patient with secondary hyperparathyroidism, the BTH is trending up, and it seems that the patient has high turnover bone disease with hyperphosphatemia. He is already on a good dose of phosphate-lowering therapy and on a good dose of vitamin D receptor analog, but his IBTH is above 700. So on the higher level, as you know, that the key DIGO guidelines is to keep the BTH between 2 to 9 folds of the upper limit of normal. So we'd like to keep it between 300 to 500. Um, so recently, his IBTH is trending up. So we don't only look for a single number, but we see the trend. Is it going up or down? Because if we don't do anything, probably the BTH next month will be 800 or so. So we have to do something to stop the BTH from going up. Most importantly, we can add cinacalcet because also it will lower down the serum phosphorus level, and it will help also with the positive calcium balance. So the serum calcium level is 9.8. So we have a room here to add cinacalcet. Other options are not correct because increasing the baricalcitol from 4 to 10 mic with each dialysis can put the patient on a positive calcium and phosphorus balance and can increase cardiovascular calcification. And adding calcium acetate as a phosphate lowering therapy will increase the positive calcium balance and also the cardiovascular calcification risk. It's too early to refer the patient for parathyroidectomy. We don't usually refer the patient for parathyroidectomy till the BTH is at least 800. Um, and in this case, we have to optimize the medical therapy first. If we fail to control the hyperparathyroidism, if the BTH is going up instead of adding the maximum tolerated dose of cinacalcet, we can think about parathyroidectomy. Thank you so much. And I'm happy to see you answering the questions right. Have a good rest of your day.